Okay, so welcome to this next video in which we're talking about the use of beta-2 agonists in the treatment of asthma. Okay, right, so we are talking just briefly about the pathology of allergic asthma. Okay, so what happens initially is that you get the primary exposure to the allergen, basically. So you inhale in the allergen for the first time. Okay, you then initiate a humoral adaptive immune response against this allergen, and this ends up producing immunoglobulin E. Okay, so this is what's known as a type 1 hypersensitivity reaction. Okay, so when you initiate a adaptive immune response that produces IgE against an allergen, which is an antigen that doesn't actually deserve an immune response being initiated against it. That's why this is called a hypersensitivity reaction, because we are initiating an immune response against something that is unworthy, so we're hypersensitive, basically. We are responding to something that really we should not respond to, something that's innocent, innocuous. Okay, now there are many different types of hypersensitivity reaction. This is a type 1 hypersensitivity reaction because it's resulted in the production of immunoglobulin E against this allergen. Okay, right. Now, how does this then lead to asthma? Well, when you produce this immunoglobulin E, certain cells that are within the lamina propria of the bronchi can have this IgE mounted on their surface, okay? So the fixed region of IgE molecules can bind to a receptor that is on the surface of mast cells in the lamina propria. Okay, and we've discussed that this receptor is known as the Fc epsilon R1 receptor, which I'm showing here in blue. Now, okay, let's just discuss mast cells for a moment. So, mast cells are a cell that you have dispersed all around your body. So it's in all your tissues, okay, and it's a sentinel cell. It's on the lookout for invading pathogens, basically, okay, and when it finds invading pathogens, it starts releasing all sorts of alarm signals, basically, and now it's armed against this allergen because it's got this IgE that is targeted specifically against this allergen, and that's mounted on this Fc epsilon R1. So if the allergen comes over to this IgE, binds to this IgE, what it will trigger is it will trigger the activation of the Fc epsilon R1, and this will then trigger the activation of the mast cell. Okay, so now what's going to happen is you're going to get secondary exposure to the anti-allergen, okay? So, long ago you had the primary exposure, the first ever time you were exposed to this allergen. Now, every time you're re-exposed to the allergen, this will be called a secondary exposure, and the allergen will go into your airways, and some of it will end up in the lamina propria of these bronchi, and this will bind to the IgE that's against this allergen that is mounted on the Fc epsilon R1s on the mast cells, and then that will activate the mast cell. Now, what do mast cells do once they have been activated? Well, they're going to release a whole bunch of pro-inflammatory cytokines. Okay, now one of the key ones that mast cells are going to release is histamine. And in fact, mast cells are very filled up with granules, okay, little vesicles that have histamine within them. Okay, so these are histamine granules within the mast cells here. So they have lots of these granules, as they're called, of histamine here. Okay, now if the mast cell becomes active, it can exocytose these vesicles containing the histamine into the extracellular space. Okay, so when the mast cell becomes active, one of the things that is going to happen is this degranulation of the mast cells, where the mast cells degranulate, the granules fuse with the membrane, and you release histamine into the extracellular fluid. So you're going to get a huge amount of histamine being released into the lamina propria of your airways, okay? In addition, the mast cells start producing leukotrienes. Now, there are two main divisions of leukotrienes. There is leukotriene B4, okay, often abbreviated to LTB4. So this stands for leukotriene B4. And then there are the cystinyl leukotrienes. Okay, and these are often abbreviated to cis-LT. Okay, and this stands for cystinyl leukotrienes. Now, there are many different leukotrienes that would all be considered cystinyl leukotrienes. Okay, so there are 3 specifically. So leukotriene C4 is a cystinyl leukotriene. Leukotriene C4. Leukotriene D4 is a cystinyl leukotriene, and leukotriene E4 is also a cystinyl leukotriene. So there are these 3 separate leukotrienes which are all considered cystinyl leukotrienes. Right, so the mast cell will start to release cystinyl leukotrienes, which will abbreviate as cis-LT, and it will also start to release leukotriene B4. In addition, it will start also to release tumor necrosis factor alpha, TNF-alpha. Okay, right, so these 4 types of pro-inflammatory mediator are now going to lead to the asthmatic attack, okay? So it's this activation of the mast cells that leads to the release of all these pro-inflammatory mediators here, which are then going to cause the asthmatic attack. Now, the asthmatic attack can be divided into 2 main stages, okay? So let's do this division here. So, you have the immediate phase of the asthmatic attack, which occurs very quickly. So it's going to occur within minutes, basically, of the mast cell activation, okay? And in the immediate phase, what happens is you get an acute inflammatory response being initiated, and you also get contraction of the smooth muscles which surround the bronchi. Okay, so the immediate phase is going to be caused by histamine that's been released by the mast cells. It's also going to be caused by the cystinyl leukotrienes, and finally also by the leukotriene B4. Okay, so tumor necrosis factor alpha, this is going to cause a later phase. So 3 out of the 4 pro-inflammatory mediators that we saw that mast cells release, these 3 are going to be responsible for the immediate phase, and tumor necrosis factor alpha is going to be responsible for the late phase. Okay, so let's see the immediate phase of an asthmatic attack firstly. Okay, so histamine and cystinyl leukotrienes are going to diffuse backwards, okay, backwards from the lamina propria to the more outer layer, the more peripheral layer, which is the smooth muscle cell layer over here. So they're going to diffuse backwards to the smooth muscle cell layer, and they're going to cause contraction of the smooth muscle cells. So histamine is going to act on H1 receptors on the surface of the smooth muscle cell. So let's say this is a smooth muscle cell here, and smooth muscle cells are often abbreviated to SMCs. Okay, so smooth muscle cells have H1 receptors on their surface. So here is a histamine 1 receptor. Okay, and histamine is going to come and act on the H1 receptor here, and that's going to activate a GQ coupled pathway, which will lead to the release of intracellular calcium stores, which will cause contraction of the smooth muscle cell. Meanwhile, cystinyl leukotrienes are going to come and work on another GQ coupled receptor, okay, which is the cystinyl leukotriene receptor, and it's the cystinyl leukotriene receptor type 1. So there are 2 cystinyl leukotriene receptors, which are both GQ coupled, but it's mainly the cystinyl leukotriene receptor 1 that's on a bronchial smooth muscle. Okay, so the cystinyl leukotrienes will come and bind to the extracellular domain of this receptor and then trigger its activation, and it will then work again for a GQ coupled pathway to lead to the release of intracellular calcium stores. Okay, so these both lead to the contraction of the smooth muscle cell. Okay, and when the smooth muscle cells all contract, remember the ring is going to constrict, and that's going to cause bronchoconstriction. Okay, so all the airways are going to narrow because of this contraction of the smooth muscle cells which surround them. Meanwhile, you're also going to get something else which is going to happen. So it's not just the contraction of the smooth muscle cells which causes the obstruction of the airways. This is going to contribute hugely to the obstruction of the airway, but at the same time, histamine is also going to diffuse forward. Okay, so remember, all of these pro-inflammatory mediators have been released by the mast cells, which are within this lamina propria here in red. Okay, and some of them can diffuse back to the smooth muscle layer here, but some will diffuse forward to the the epithelial cells here. Okay, and not to the epithelial cells. Forget that. They're going to diffuse to the endothelial cells of the blood vessels in the lamina propria. Okay, so forget the epithelial cells, sorry about that, getting a little carried away. They're going to cause the inflammatory response in these blood vessels. So remember, in the lamina propria you have these blood vessels, and certain of these pro-inflammatory mediators will diffuse over to the blood vessels and will act on the endothelial cells of those blood vessels. So, two of these that are going to be very important are histamine and leukotriene B4. So histamine will act again on H1 receptors on the surface of endothelial cells and will cause what is known as type 1 activation of the endothelial cells. Now, what happens when endothelial cells undergo type 1 activation? Well, firstly, type 1 activation occurs very quickly. It occurs within minutes. Okay, so the histamine arrives at the endothelial cells, causes type 1 activation. This occurs within minutes. Now, what actually occurs? Well, if it's acting on a little arteriole, what it will lead to is vasodilatation. Okay, so there are going to be three main types of blood vessel in the lamina propria. There are going to be tiny little terminal arterioles. Now, do not confuse these for arteries. Arteries are the massive great things that you learn about in anatomy. These are tiny, tiny little tubes, okay? But they do have a layer of smooth muscle cells around them. Okay, so it's going to cause vasodilatation of the terminal arterioles, the arterioles that are just before capillaries. So let me just outline this. So what you'll have is a terminal arteriole here, which will then split into capillaries, okay, like so. So here are the capillaries, and then the capillaries will reconverge together to make a post-capillary venule. And these are the three types of blood vessel you're going to have within your lamina propria. You're going to have these terminal arterioles, which have an endothelial cell layer on a basement membrane, and then with a layer of smooth muscle cells around the basement membrane. Then you have the capillaries, which are tiny, tiny one-cell thick blood vessels where you just have a single endothelial cell making up the entire circumference, and this is just sitting on the basement membrane. And then finally you have the post-capillary venules, which are bigger vessels, okay, but again, their wall literally consists of an endothelial cell sitting on the basement membrane, and that's it. So here are the post-capillary venules. Okay, so these are all tiny little blood vessels, and for that reason they're all referred to as the microvasculature, little blood vessel systems, okay? Right, so it's going to cause type 1 activation in the terminal arteriole endothelial cells will cause vasodilatation of these terminal arterioles, leading to increased blood flow through the lamina propria. Okay, it's also going to lead to increased vascular permeability. You're going to get endothelial contraction, where the endothelial cells pull apart, okay, and open up little gaps in between themselves. And this will mainly occur in the capillaries and the post-capillary venules, opening up gaps in the endothelium, which will allow fluid from the blood to move through these gaps into the interstitial space. You're going to get fluid moving from the blood into the lamina propria. Okay, so that will cause swelling of the lamina propria, and when the lamina propria swells, what's going to happen is it's going to push on the basement membrane and the epithelial cells underneath that, and it's going to push them inwards basically, and that also lead to the narrowing of the airway. Okay, right, and the purpose, of course, of that endothelial contraction is to build up what's known as an inflammatory exudate, which is this fluid that you brought in, which will contain a whole bunch of proteins from the blood, which are going to be useful in controlling a pathogenic infection. After all, that's what we are initiating. We're effectively initiating the inflammatory response in the bronchioles, the bronchi and the bronchioles. Okay. And the problem is that the pathogen is non-existent. It's an innocent little piece of pollen or something. That's why it's a hypersensitivity reaction. If you were initiating this against some foul, deadly virus, then it would be perfectly reasonable, but you're initiating it against pollen. Okay, and also what you'll get is leukocyte recruitment, and the main type of leukocyte that type 1 activation is capable of causing the recruitment of is neutrophils. So you're going to get neutrophil recruitment from the blood into the lamina propria. Now this is also going to contribute to the swelling that you'll get in the lamina propria. Okay, and leukotriene B4 will also contribute to this neutrophil recruitment. It's absolutely fantastic at leading to neutrophil recruitment. So where there is very high levels of leukotriene B4 in interstitial fluid, you get a huge accumulation of neutrophils there. Okay, so these are the two things that are going to happen. You're going to get swelling of the lamina propria because of the inflammatory response. You're also going to get contraction of the smooth muscle cell layer, leading to bronchoconstriction. So both of these things are going to narrow the airways down. Okay, and the problem with that is that it's going to impede your breathing. Okay, so when you breathe, it will now sound very strange because you're forcing air through very narrow tubes. So wheezing will start, okay? And you'll also have shortness of breath because you're not getting enough air into your lungs, okay, to provide adequate gas exchange. Now, if this is very, very extreme, what can happen, and this is why asthmatic attacks need to be taken extremely seriously, it can lead to hypoxemia, too low oxygen levels within the blood, okay? And obviously if you've got too low oxygen levels in your blood, your peripheral tissues can potentially start to die, the brain can start to die, and if the brain does die, it's a race obviously between the two most important tissues of the body, the brain and the heart, which one dies first basically. Usually it's the brain. So what can actually happen is it can lead to what's known as asphyxiation, and this is basically a nice big word to describe dying because of lack of oxygen, okay, or some problem with breathing. So asphyxiation means that you die because of problems with breathing. Okay, it's also sometimes known as respiratory failure, although respiratory failure is a very broad term. Okay, it basically means that the respiratory system has failed the rest of the body. Okay, so asphyxiation is less of respiratory failure, and that's fatal. So people die because of asthmatic attacks, so it's a very, very serious disease. Okay, now that's the immediate phase of an asthmatic attack, that you get this obstruction of the airways. Okay, the late phase is triggered by the release of tumor necrosis factor alpha from the mast cells. So, histamine caused type 1 activation of endothelial cells, which was extremely rapid because it did not involve any changes in protein synthesis. Tumor necrosis factor alpha causes what is known as type 2 activation of endothelial cells. Okay, now this is much, much slower because it involves changes in protein synthesis. In fact, everything type 2 activation is a change in protein synthesis. Okay, so the beating soul of type 2 activation is that you change protein synthesis. Okay, so you start making proteins that you would never have made before. Okay, now this importantly leads to more leukocyte recruitment, so it's going to lead to more white blood cells being moved out of the blood vessels and into the interstitial fluid of the lamina propria. Now, type 2 activated endothelial cells are capable of recruiting a whole bunch of far more exciting white blood cells than type 1 activated endothelial cells were. So type 1 activated endothelial cells they were really only capable of recruiting neutrophils. That's all they did. Whereas type 2 activated endothelial cells, they can recruit the works, basically. So, type 2 activated endothelial cells start to recruit in T helper 2 cells. Okay, now it's a little bit of a mystery as to where these T helper 2 cells come from and to which antigen they're actually primed against, because you might think, well, surely these are going to be T helper 2 cells that are primed against the allergen that the whole asthmatic attack was launched against, but we aren't actually sure about that, because we don't think that you would have had time to activate the T memory cells and start the production of T helper 2 cells like that. We don't think you would have had time by the time this late phase occurs. And I should say, the late phase usually occurs within a few hours, basically, and that's because type 2 activation takes a few hours, okay, 1 to 2 hours. Okay, whereas type 1 activation takes minutes, okay, which is why the immediate phase is very, very quick, and contraction of smooth muscle cells occurs very, very quick. Okay, then in type 2 activation, you start recruiting these T helper 2 cells. We're not sure as to whether these T helper 2 cells are actually primed against the allergen or not. The important thing is that they come in and start releasing certain molecules, certain cytokines. So the big cytokines they start releasing are interleukin-5 and also a cytokine known as granulocyte monocyte colony stimulating factor, which is also known as colony stimulating factor 2. Okay, so I'll have to write this one's name out at least once. So GM-CSF stands for granulocyte macrophage. Colony stimulating factor is the CSF. Okay, colony stimulating factor, not cerebrospinal fluid. Okay, colony stimulating factor. And this is also just called colony stimulating factor 2, which is in some ways a more sensible name for it, but granulocyte macrophage colony stimulating factor is probably more common. Okay, now these things both lead to the recruitment of eosinophils into the lamina propria. Okay, now we're not really sure how they lead to the recruitment of eosinophils. What we know is that if you have very high levels of interleukin-5 and granulocyte macrophage colony stimulating factor in some interstitial fluid, then it leads to eosinophils accumulating in that same place. We don't quite know how it works. We don't think it causes a change on the level of the endothelial cells. So we don't think it goes over to the endothelial cells and tells them to start recruiting eosinophils. Instead, we think it acts directly on the eosinophils, and that's more difficult to understand how that would work. So it seems to act on eosinophils, which just happen to be passing by. It seems to activate them so that they can now be recruited by the endothelial cells, and then they're recruited by the endothelial cells into the area. Okay, so you get eosinophils arriving in this lamina propria. Okay, now these are bad cells. They are very, very dangerous. They are one of the most dangerous cells the immune system has. These are the cells that you use if you have some multicellular parasite that you will have to kill. Something that no other cell of the immune system would stand a hope against. Okay, so these cells can release really, really cytotoxic molecules. So let me just draw a little picture of an eosinophil. So eosinophils are called eosinophils because they stain very well when you stain them with the dye eosin. Okay, so eosin is a dye, eosin. Okay, and it's a red dye. So, eosinophils, when stained with eosin, they stain bright red, and they also have a bilobed nucleus. So the nucleus has this bizarre structure where it has two sort of lobes and then a little tube connecting the two lobes. And for this reason, eosinophils are often compared to a burnt, sunglasses-clad face, basically, because the nucleus looks like a pair of sunglasses, and then usually the cytoplasm will be bright red. So let me get my red pen out. Okay, so usually they'll be bright red. In fact, let me do this properly. Okay, so I'll show you what an eosinophil would look like if you ever see one on a histological slide, and you won't be able to get a medical degree without seeing one at least once on a histological slide in histopathology. Okay, so here is our eosinophil. Okay, now these eosinophils have granules within them. Okay, so it's a granulocyte. It's a type of granulocyte. So there are 3 types of granulocyte. Neutrophils are a granulocyte, eosinophils are a granulocyte, and there's one final type known as a basophil, which does very little as far as we can tell. It is involved. It's kind of like a mobile mast cell. But they're very, very low levels within the blood. You will never, ever see one on a blood smear. Okay, so these eosinophils have these granules, little vesicles within their cytoplasm, which are filled up with incredibly cytotoxic molecules, which they can release if they are pushed into doing so. Okay, so they're going to come into this interstitial space in the lamina propria, and they're going to then be activated by these same molecules that cause them to recruit there. So interleukin-5 and granulocyte macrophage colony stimulating factor, these were involved in bringing the eosinophils into the lamina propria, but now they're also going to actually act on them directly. Okay, so these are going to activate them as well, and they're now going to start releasing these horrors that are within these granules. Okay, so what horrors are within the granules of eosinophils? Well, one of the horrors is major basic protein, okay, which is often abbreviated to MBP for short. Okay, oops, how am I going to rectify that? Can't. Okay, just get rid of that. MBP. Okay, and the other is a protein known as eosinophil cationic protein. Okay, so again, this is a horrible protein. Both of these proteins are extremely cytotoxic, so they just kill cells. So the poor old epithelial cells are going to get blasted with major basic protein and eosinophil cationic protein. So let me show you the picture of the bronchus again. Okay, so the eosinophils are in this lamina propria here, and they're now releasing these horrible proteins, and these poor epithelial cells are going to get blasted with it, basically. So you start to get epithelial cells dying, and you gradually damage your bronchi. Every time you have an asthmatic attack, you are damaging your bronchi because of these eosinophils coming in. Okay, and what this gradually leads to is it leads to the exposure of neurons. Okay, so in the lamina propria you have sensory neurons, and these sensory neurons can gradually end up exposed to the lumen of the airway. And this is what then leads to the development of non-allergic asthma, because these sensory neurons being exposed to the lumen of the airway means that if you inhale very cold air or noxious chemicals or environmental pollutants, they will activate these sensory neurons, and these sensory neurons can then lead to, firstly, the contraction of smooth muscle, okay, that surrounds the bronchus, and also they can lead to neurogenic inflammation, i.e. they can lead to the asthmatic attack just as well as the mast cells can lead to the asthmatic attack. Okay, it's now triggered by neurons rather than mast cells, but effectively this pathology is, well, the overall symptoms, what it causes is going to be the same. So that's how allergic asthma that can then go on to cause non-allergic asthma. Okay. However, there are some people who get non-allergic asthma without ever having allergic asthma, and we don't understand how that quite works. Okay, so the other thing about the late phase is that these eosinophils also produce cysteinyl leukotrienes, which then go and act on the smooth muscle cells and cause contraction. So you've still got contraction of the smooth muscle of the bronchi in the late phase, basically, because the eosinophils are producing cysteinyl leukotrienes. Okay, it won't be as intense as in the immediate phase because you've no longer got as much production of cysternal leukotrienes or as much histamine around, which is a very powerful bronchoconstrictor, but you will still have some there. So you've still got some contraction of the smooth muscle cells leading to some constriction, okay, and you've also got these eosinophils being accumulated in the late phase, which are doing permanent damage to the walls of the bronchi. Okay, so in the next video what we'll turn our attention to is how to use beta-2 agonists to treat asthma.